Welcome to this edition of Lipid Insights. I'm Dr. Alan Brown, your host and past president of the National Lipid Association. I'm here with Dr. Dan Soffer and Dr. Kevin Maki, two other past presidents of the NLA, discussing a document that actually just got published today, which I'm excited to hear a little more about and what the background was for the development of the document. And the document is on the role of apolipoprotein B in the clinical management of cardiovascular risk in adults. This is an expert clinical consensus from the National Lipid Association, which is a document that has a lot of clinical judgment in it as well as data. So it's not quite the same as a guideline, but it's expert opinion. And I'm a big believer in expert opinion, especially where we don't have prospective randomized trials. This topic, Dan, has a lot of data. There's lots of data about ApoB and risk. And I know that you personally really feel strongly about the importance of ApoB as not only a risk assessment tool, but possibly a target of therapy. So why don't you tell me a little bit about how you guys decided to proceed with this document, what you're hoping to accomplish.
Alan, thank you so much for having Kevin and me here to talk to you about this today. It is very important to me and very exciting to have this opportunity. In my practice clinically and at the level of the teaching that we do at the NLA, I've been thinking about ApoB for a long time. Kept hoping that it was going to be incorporated into guidelines, kept hoping that it was going to be incorporated into normal practice and not just in the realm of clinical lipid specialists. And instead of just continuing to hope it was going to find its way there, decided that we better assert its role in clinical management, even if we don't have reams of data of prospective clinical trials that assess the outcomes in people based upon their ApoB. Part of the rationale is mechanistic, and while I'm a full-time clinician, I think about mechanisms of disease a lot because there are so many gaps from cardiovascular outcome trials in how we manage care. So you always have to consider mechanisms of disease in clinical management, and I just couldn't get past the common sense interpretation of the expectations of the role of ApoB compared to LDL cholesterol and how important it is, and felt that the preponderance of evidence was strong enough now to write an expert clinical consensus statement, as you point out, not a guideline, but a consensus statement.
So this is going to be an interesting conversation. We're talking about the role of apolipoprotein B, which is ApoB 100 if you're a purist. ApoB 48 is on gut-derived lipid particles like chylomicrons and their remnants, which are gone by the time we do a fasting lipid profile in most people. And it's not just talking about the role of ApoB, but in management of cardiovascular risk. So we're looking at an opportunity to maybe be better at assessing risk and treating risk. So Kevin, there are three ways we can look at particle numbers of atherogenic particles: ApoB, non-HDL, and LDLP, or particle number. What made you guys focus on ApoB versus the absolutely free non-HDL option?
Well, non-HDL is better than LDL cholesterol. And so when it comes to clinical management, that's a good place to start. But there are still people who, despite having controlled levels of both LDL and non-HDL cholesterol, will have an elevated level of ApoB. And we know when there's discordance, when the ApoB level is higher than would be predicted based on the LDL cholesterol or non-HDL cholesterol level, risk follows ApoB. So it's the concentration of particles that's important. Now you can get a particle concentration by using It's something like NMR to measure LDL particle concentration, but there are multiple methods out there for LDL particle concentration. They don't always agree with one another completely. And so we thought that ApoB is the best standardized method, and it's even going to be better standardized soon. But we thought it was the best method for use by clinicians. Not that the others don't have value, they do, but we thought that ApoB was a good place to start in terms of assessing particle burden.
So I think just because people aren't doing a good job is maybe not a reason to move to a different metric for treatment. I think we always hear that we're not anywhere near guidelines from 20 years ago for LDL. And one of the arguments against ApoB is now we have to kind of wipe the slate clean and try to teach everybody a new thing. But it actually doesn't seem that complicated. You'd have one number. So, Dan, I wonder if you could address that issue and then how you would approach kind of reteaching everybody of where we should be with ApoB if that's what your goal is. And then secondly, tell us a little bit about the bullet points of what is in this document that people should be looking for when they start to read it.
Yeah, thank you. I think it's worth pointing out that we already are not doing very well in managing the things that are entrenched in clinical care. So we definitely need to do better. But that doesn't mean that we don't need to push the envelope, do better in terms of what metrics we use and how we approach those metrics at the other end of the spectrum. So finding ways of providing the best care for the most amount of people and not turning our back on those who want to do even more at the same time is a very important part of what we do as an organization. I think I learned that point from you, Alan, when you talked about what does it mean to be a lipid specialist. Of course, we want to provide as much for our systems in terms of optimizing care for everybody, but we also want to be able to manage things at the tip of the spear where people have unique characteristics and require clear one-on-one approaches to care. ApoB is a nice bridge for both of those things because it does give us a very simplified way to look at the role of lipids and lipoproteins and their impact on atherosclerosis. And it also gives us a tool that enables us to clarify the care for our patients who have unique or severe lipid disorders. So it does both of those things. And for that reason, I think it really stands as the principal target potentially in the care of our patients. I would like to say that the care that we provide that's most entrenched in literature at the highest level of evidence is statin use for the reduction of ASCVD events and statins which primarily were thought of as targeting LDL cholesterol lowering. And all of the numerous clinical trials that have been done in the past that go into the meta-analyses that help us understand what we should be doing and that make up the strongest evidence that support the guidelines is an LDL cholesterol-based approach. And so there's a strong bias based upon how the science was accumulated in the preceding generations. But still, we know that the emerging science, or even already established science, though not at the same level, strongly supports the use of ApoB as a simplified metric that outperforms LDL cholesterol for risk assessment and probably outperforms non-HDL cholesterol for a risk assessment, and certainly outperforms both of those metrics when we're trying to understand the more complicated patients.
Yeah, it's very interesting that the patients who drove all the outcome benefit in statin trials are the ones with the low HDL and high triglycerides. They drove the majority of benefit. Those would be the people you'd expect to have the high ApoB levels, not necessarily the patients with the high LDL levels. So I think a lot of people don't realize that and often reach for other therapies in those patients where really the strongest statin data is.
Alan, I'll tell you an anecdote. I was at a conference 20-some years ago when I was an upstart burgeoning lipid specialist, and my colleague Dan Rader was presenting, and I thought I was being so smart. I was citing a Christy Ballantyne paper that showed the impact of simvastatin in the 4S trial in patients with high triglycerides, low HDL cholesterol. And he looked at me and said, "Oh, well, that's very insightful of you." And I think it was that spark, that little communication, that led me actually down the lipidology road. So
interesting. So, Kevin, can you kind of tell us what were the bullet points of the article in terms of what topics did you cover, and then a little bit about how you came to clinical recommendations, what kind of data supported those recommendations?
Sure. There's an overview of the evidence supporting ApoB as a driver of ASCVD risk, and that's both from the standpoint of observational studies and randomized controlled trials. And then in addition to that, we look at the relationship between LDL cholesterol and ApoB, both in the untreated population and then people in clinical trials on treatment. And what you see is that with lipid-lowering drugs, typically you lower LDL cholesterol more than ApoB. So the ApoB LDL cholesterol relationship is shifted, and so you get regression lines that are parallel to one another. And so for a given level of LDL cholesterol in someone who's on treatment, they tend to have higher ApoB. And so we use that as a way to estimate where would thresholds be that correspond to the lipid levels that were obtained in randomized controlled trials that were associated with the lowest risk. And so we came up with thresholds, just like we have thresholds for LDL cholesterol and non-HDL cholesterol. We added thresholds for ApoB, and the threshold is basically a number where you say if the patient remains above this number, then intensification of therapy should be considered. And conversely, in some patients where you may be considering intensification of therapy, if their ApoB level is not elevated, then it may not be as urgent to do so. And so ApoB is helpful for both identifying those people who are at higher risk than would be predicted based on their LDL or non-HDL cholesterol level, and people who are at lower risk than would be predicted. And so using all three as measures that you look at to assess both risk and adequacy of therapy, I think is very helpful and really not very complicated. It's three numbers, and you say, we want to be below the threshold for all three numbers in a patient who's at risk, and we want to lower that risk. And so you get all three numbers, and you say, are we there or not? If we're not, then we may consider additional therapy.
So Dan, a skeptic might say we've had studies where we added additional therapy on top of statins, whether it be fibrates or niacin, where we may potentially have changed the ApoB levels by adding them without much outcome difference. So how do you address that particular issue? And, you know, again, skeptics are going to say, show me the meat. I want to see a clinical trial where ApoB is a target of therapy, not just a risk.
Yeah, I count myself amongst those people. I definitely want to see that, and that was one of the things that we called for in this paper was inclusion of ApoB with all future clinical trials, cardiovascular outcome clinical trials going forward that pertains to lipid and lipoprotein monitoring. The examples you give of niacin and fibrates are different examples, and they have different impact. Niacin, I have to say, is very confusing to me. Right? It does everything right, except that it also must cause harm, because the on balance, when added to statin therapy, results in neutral impact on cardiovascular events, despite improvements in every lipid and lipoprotein parameter. Fibrates are more complicated, or maybe complicated in a different way, I should say. Fibrates do not as consistently lower ApoB as niacin, but they are very powerful triglyceride-lowering therapies. And it seems to me that at least one of the failures of fibrates in clinical trials when added to statins is that they've had negligible or little impact on ApoB. And I know that I at least like to think that that's part of the reason for their failure, because they, as monotherapy, have strong evidence supporting their use, whereas the evidence for niacin was never strong in any clinical trial.
You know, I'll just add with fibrates, the effect of fibrates on LDL cholesterol and ApoB depends on the baseline levels of triglycerides and LDL cholesterol. So if you give a fibrate to someone with type 2A dyslipidemia, so they've got elevated LDL cholesterol, it lowers LDL cholesterol, it lowers ApoB. But when the triglyceride level goes up, you add fibrates to statins or even fibrates as monotherapy, and you don't see much reduction in ApoB. And to reiterate what Dan said, the most likely explanation in my mind for why we've had failures with fibrate trials is they haven't really lowered ApoB, and risk follows ApoB more so than LDL cholesterol or non-HDL cholesterol.
So with that said, you're really saying that if someone has an elevated ApoB, you're going to intensify your LDL lowering therapy. Is that correct? So what about the addition of something like ezetimibe or bempedoic acid? And would that be the approach if your ApoB remains high despite getting LDL to the currently recommended below their threshold?
One of the things we share in the paper is the specific impact on LDL cholesterol lowering and ApoB of the different therapies. We share the specific impact of statins on LDL cholesterol and ApoB, ezetimibe, PCSK9 inhibitors, and bempedoic acid. And so as a reference tool, readers can look at that and see what the expectations are from each of those therapeutics. We don't have as clear evidence from lifestyle modification because lifestyle modification means different things to different people in different circumstances. And so we didn't include that as a specific therapeutic with specific outcomes for ApoB lowering.
So, a lot of times we say that the best guideline is the one that fits in your shirt pocket. And one of the reasons that I believe that all of our evidence-based guidelines over the years have not changed practice as much as we had hoped is because there are too many pages and there's too many options. And, I believe that they're excellent documents based on fantastic review of the literature and that everything in there is based on solid evidence. But if you tell people take an aspirin as a guideline, 90% of people are at guideline. If you tell them add up risk factors and if they have more than two, or if their LDL should be X or Y, or a complicated flow diagram, then you start to see that patients don't get adequately treated. So it seems to me that having ApoB as a way to determine whether you've adequately lowered risk or not is something you could fit in your shirt pocket. I just wonder if you would comment on that. And it also sounds to me like you're not advocating throwing out the current guidelines. You're just saying that if you really want to assess risk, get to the numbers that we think are right now and then do the ApoB to decide whether more needs to be done. Am I correct on that?
Yeah, I think so. I think you both recall very well the NLA recommendation statement in 2014 and 2015, where it was advocated that non-HDL cholesterol should be the primary target of therapy and LDL cholesterol would be the secondary target. That never caught fire. We didn't gain any traction with that recommendation. It was a simplistic approach, and it would be a very effective approach to managing care because once you get the non-HDL cholesterol to very low levels, the LDL cholesterol is going to be taken care of. Same thing would occur with ApoB. I don't think the NLA was in a position, based upon the evidence available, to suggest that the evidence is strong enough to solely pursue ApoB as your target. But I think the evidence is clear enough from observational data to support using it as a decision tool in taking care of patients at the clinical level. And how that fits into the evidence base for a guideline where the level of evidence needed to be incorporated into guidelines is such a high bar, I think we're still years away from being able to incorporate it at that same level. I just want to say also that Kevin made the comment about how the thresholds for ApoB were derived, and they truly were derived, whereas the LDL cholesterol thresholds that were in the 2018 AHA-ACC multi-society guidelines are empiric. They are based upon clinical trial study design, and that is the strongest, highest level of evidence, and we just don't have that for ApoB or non-HDL cholesterol.
But I would point out that we do have many trials where ApoB was measured, and so it's a post hoc type of analysis. It wasn't pre-specified in the design of the study, but you can look at the relationship and you can see that it comes out just the way you would expect it to if, in fact, it's the concentration of atherogenic particles that's driving the risk. And so while we don't have the same level of evidence based on pre-specified trial design, we have pretty strong post hoc evidence.
And I think our audience appreciates that kind of evidence. I often say that if I hear music behind me and someone says you can't say there's speakers unless you turn around and see them, that's not necessarily true. I'm pretty comfortable there's speakers if I hear the music. So I think we can listen to the music until we have the absolute data. One question, Kevin, that I think will probably come up with the audience if they're not real familiar with ordering ApoB is it expensive? And number one, and you already mentioned that it's getting more accurate. I don't think I've ever had a payer deny an ApoB level, so I'm assuming it's not very expensive.
Well, this is one of those things that is frustrating. So it shouldn't be expensive, and in many places it's not expensive, but occasionally you order an ApoB from a lab where they don't run ApoB very much, or they send it out to another lab, and then they add a big markup. And so I think Dan said he had a patient come to him with a big bill, like hundreds of dollars for an ApoB measurement. Yeah. I had a patient in one of our clinical trials who we ran an ApoB outside of the trial, and he got charged $130. And, I showed him the bill that we got from the lab that we use, and it was about, $17. And so, 17 to 130 or many hundreds of dollars is really an unacceptable variation. And so that's one of the things that we call for, that we need payers to, really allow ApoB measurement, not classify it as an experimental test. And then also we need laboratories to, step up and charge reasonable prices. We're all for everyone, making some profit, but there's reasonable profit and then there is unreasonable profit.
Well, my guess is that the more often it's ordered, the lower the price is going to be because you'll have a more automated way to measure it. But you said that you derived the cut points in the paper. Can you tell us a little bit more about how those are derived, and then what are the cut points that our audience might want to know about?
Sure. So we have three numbers essentially for LDL cholesterol thresholds, and those are 55, 70, and 100. And so we looked at both the treated and the untreated populations, and we said, well, what would be the ApoB concentration that would correspond to those based on simple linear regression? And so you get one set of numbers for untreated and a slightly different set of numbers for treated people, and we just took the average of those two. And then we rounded up to make the numbers clean. They have to end in 0 or 5. We don't want any, 63s or 72s. And so for the corresponding numbers, for LDL again, 55, 70, and 100, the corresponding numbers for ApoB thresholds would be 60, 70, and 90. And, again, very simple, straightforward.
There's your bullet points, Alan,
yeah,
right there.
Those are good bullet points. 60 for the very high-risk patients, 70 for high risk. I still struggle with separating that. And then 90 for the borderline to intermediate risk. And this is based on the guideline definitions, right?
Correct. So,
Dan, give us a feeling for what percentage of patients who get an LDL of 55, who have ASCVD, will have an ApoB level over 60. In other words, once you've treated them to below 55. So how many people are we missing? And then number two, what would be your approach to treating them? Is it better to go up on the statin, which only lowers LDL another 6%, or is it better to add a non-statin therapy? What are your thoughts on that?
We didn't actually quantify that, but I have some qualitative descriptions of it. I'm going to be going through it with the NLA group at the main meeting. What you see is that you end up treating the same number of patients, whether you're using LDL cholesterol or ApoB, but you are treating the right patients if you use ApoB as opposed to using LDL cholesterol, because there are going to be some patients whose LDL cholesterol looks like it's above the threshold, but their ApoB is below that threshold, and vice versa. And so what you'd like to do is make sure that you're treating all the right patients. It's a little challenging because with statins and ezetimibe, they come to our patients essentially for free. They're generic drugs. My health insurance doesn't charge at all for either of those drugs. It becomes an issue when you're talking about using drugs that cost a lot of money and where you need permission from a third party to say, yes, you can take this drug, like PCSK9 inhibitor or like a branded product like bempedoic acid. And so if you need permission, they're going to go with what the guidelines say. So if you have a patient whose LDL cholesterol is below the highest risk threshold, an LDL cholesterol that's below 55 milligrams per deciliter, and your ApoB is well above 60 milligrams per deciliter, and you really need to intensify their therapy, and they're already on optimal statin and ezetimibe, it's really challenging. At this point, we hope our paper could at least justify the rationale in authorization for this medication, because I don't think right now the insurers are willing to necessarily jump to that approach for adding one of those more expensive drugs. But I think we just have to keep pushing the envelope because we know it's the right thing to do. I'm with you, though, in terms of I rarely increase the dose of statins. I think when you start doing that, you get more side effect than benefit.
So I just want to point out to our audience that we are recording this live at the National Lipid Association Fall CLU, Clinical Lipid Update. So if you hear some voices in the background, it's because we have other attendees talking. So I apologize for the background noise, but it's exciting to be doing this interview here in Dallas at the Fall CLU. So I'm going to ask each of you to kind of summarize why our audience should read this paper and what should they do clinically. So one option would be get the LDL to the guideline-based therapy and then do an ApoB. And the other option would be to do an ApoB at baseline along with the lipid profile. I don't know which is best. I'm a little confused by that. So Kevin, help me out.
Well, I'll give you my bias, which is treat to LDL and non-HDL cholesterol objectives, and then measure ApoB, and if it's still elevated, then there may be more work to do. Other people have different opinions on that, and so I don't think those are unreasonable, but from the standpoint of resource utilization, I think that the majority of people that you get to, especially their non-HDL cholesterol therapeutic objective, below the threshold, the majority of those people are going to have an ApoB level that is under threshold, but not all of them. And so it's that percentage, 10, 15, 20%, who still have an elevated particle concentration where there may be additional residual risk that can be addressed. And so that's my bias, is to wait until you've met the other objectives and then measure ApoB.
Yeah, just for our audience, I think this seems like a nebulous concept, but just think about a patient who comes to your office with a LDL of 130, HDL of 45, and triglycerides of 75, who's had a coronary event. You know that LDL needs to go down lower, and you have an idea of what their risk is in your mind. And now think of a patient who's got metabolic syndrome who walks into your office, whose LDL is 90, but their HDL is 20 and their triglycerides are 350. You know in your mind that patient is at higher risk than what you would have known if you only saw the LDL of 90, right, or of 70. So how do you assess, even though your gut is that's a higher risk patient, even though they have a lower LDL? And the argument for non-HDL is it gives you a better idea of what that patient's risk is, and it's the same argument for ApoB. You're going to get a better assessment of risk than looking at LDL in that individual. So I think for those of us who take care of patients, which I know everybody at this table does, that's kind of the concept, is trying to get our handle on when someone has a mixed dyslipidemia, particularly an insulin-resistant pattern, how do you know when enough is enough for therapy? So they tackled the non-HDL in the earlier guidelines, and they kind of went away, and the ApoB is another way to measure that. I'm just going to remind everybody that very high risk ApoB derived number should be less than 60, for high risk less than 70, and for borderline or intermediate risk less than 90, based on the document that was just published today. So thank you, Kevin, for that. Dan, what are your final thoughts on, first of all, do you agree, treat the LDL down to current guidelines and then get an ApoB? And remember, we don't want anybody who wrote guidelines getting upset with us, but, or as a lipidologist, is it fair to just get an ApoB at baseline and then help determine how aggressive and should the ApoB be targeted from that point? So what are your thoughts on that?
It only matters that you order ApoB at the right time if there's an extra cost associated with it to the patient and to the health system. And there is an extra cost, so it makes sense to be mindful. And Kevin's recommendation that, start with the standard foundational care first, then consider adding an ApoB to make sure that you're doing adequate. And I think that's a very sensible approach. And guideline authors who are thinking about how to manage care for large populations have to consider things in those terms. So I think that makes a lot of sense. I think you got it mostly right in terms of thinking about this discordance pattern as being particularly pronounced in those patients that you described with high triglycerides and or low HDL cholesterol. But I want to point out also that you don't need to have high triglycerides and or low HDL cholesterol to have discordance between ApoB and LDL cholesterol. And so if we only measure it in the circumstance where what you describe, we're likely to miss important LDL cholesterol ApoB discordance at other times too. So I think a more liberal ordering, at the initial evaluation to see who has that discordant pattern. And if you find that, it makes sense to track the response. And once you see what the pattern is, I think you can check it less frequently if you're adding expense to the care. But if you can't really see that there's a specific pattern, it makes sense to monitor the ApoB over time. And so I think clinicians have to make judgments for this. We specifically did not create an algorithm on how to manage this. We specifically kept it broad and enabled clinicians to make their own decisions. But we gave some recommendations on when it has the greatest utility and when would be a minimum time to do that.
So it's interesting. Yesterday in the clinic, I saw a very thin, fit gentleman who had an LDL of 124. Happily, he had a calcium score of 0, but he had done an advanced lipid profile, and his particle number was 2,040. So that would be somebody I worry about. The calcium score, I think, was very helpful, but there's an example of somebody their ApoB is going to be higher than expected. So usually you can just move the decimal point to the left, one decimal point, to look at what LDL the particle number should correlate with. So this is somebody you'd expect his LDL to be 200 with that particle number, and I assume his ApoB would be quite high. So I think that's what you just pointed out. He didn't have high triglycerides, but he had a really high particle number, and I think he had some other things that reduced his risk for cardiovascular events. But that was an example that I just saw yesterday of how you can be fooled.
Alan, do we have time to talk about some nuance to what you just described?
Sure.
For one thing, I think you described him as an elderly man. Is that
No,
right? Oh,
no.
I'm sorry.
He was thin.
Oh,
not
thin.
elderly.
All right. I must
As I
have
get
implanted
older,
that.
very few people are elderly.
I agree. I think the calcium score would be a far more valuable tool. Also, we didn't talk about in our paper the possibility and the occurrence of LDL particle ApoB discordance. And that's a real phenomena. And the reason that we wrote a paper on ApoB and not on LDL particle is because ApoB is a much more validated, reproducible, and easy to measure test than LDL particle. And when there is discordance between those, I think we have good enough evidence to suggest that the ApoB is actually the better test and it's more indicative of the condition rather than relying on LDL particle number in that circumstance.
So it's interesting. The only paper I know of looking at so-called advanced lipid profiles and treatment was it actually related to LDL particle number, but I think you could correlate it with ApoB. That when you give that additional information to physicians, they're more aggressive in their treatment, and those patients had better outcomes. So it wasn't really a prospective randomized trial of adding a certain drug or treating to a certain ApoB target or particle number target, but it was a real-world paper that showed that when you give that information to physicians, they treat more aggressively, and that led to better outcomes. Very, very interesting. So at the very least, you know, you give this additional information, you're going to identify people at a higher risk. I think a calcium score is helpful too, but assuming they have evidence of atherosclerosis, it may bear some significant fruit in being more aggressive. And as I've said for 30 years, can't be skinny enough, can't be rich enough, and your LDL can't be low enough. And maybe in addition to ApoB. And for 30 years, nobody has actually proven me wrong on that statement.
Hold on, I have to write that down.
So I want to thank Dr. Kevin Maki, Dr. Dan Soffer for really insightful discussion, and encourage everybody to read this paper. It is an expert consensus document, so there is expert opinion. There's some derivations that are not from prospective randomized trials, but you know, we've got two fantastic scientists as co-authors of this paper, along with many others. So I think you're going to find it very useful to read through and then use your clinical judgment about how you will incorporate ApoB into your practice.
Alan, I just want to add, you know, you mentioned the other authors. There are some acknowledgments in the paper, and, you know, I think if you've been in this space long enough, you know that Alan Snyderman has been a driving force in the role of ApoB and how we all manage care, and much of the work has been done by Alan and his group and was inspirational for the paper, and I think it's worthy of acknowledging that.
I think that is absolutely true. He's probably really thrilled to see this manuscript coming out as an expert clinical consensus from the National Lipid Association. And looking at all the other authors on this paper, they're just who's who of, you know, good scientists and high-level lipid specialists. So thanks to both of you for adding to the literature. I'm a big believer in consensus documents, especially in spaces where we don't have prospective randomized trials.
Thank you so much for giving us a chance to talk about it.
Thank you, Alan.
And thanks to you for listening in on this version of Lipid Insights. I hope you found it valuable, and I encourage you to take a look at the document, which is published in the Journal of Clinical Lipidology.